my great pleasure and privilege to invite the speaker of today, Dr. Gautam Khastgir. Everybody knows him very well, and he is recipient of Wellbeing Research Grant of RCOG London, published many research papers on infertility, hormone therapy, endoscopy surgery, RCOG accreditation of subspecialty training in reproductive medicine and surgery at level 3 endoscopic surgery, medical director of Birth and Advanced Fertility Center, head of gynecoscopy, provided hands-on training to over 250 doctors in gynecological endoscopic surgery. Organizing secretary of ISAR 2018, chair of ISAR Bengal 2020-22, and he is elected member of ISAR Executive Committee 2020-22. So I invite Dr. Gautam for his talk on unexplained infertility. Dr. Gautam, please. You are muted.
Thank you very much, Madam, for that kind introduction. First of all, my pranam to respected Chandravati Madam, and my respect to the chairpersons, and my greetings to all the UP ISAR chapter members. Thank you very much for accepting this invitation of joint webinar, which we have just heard from Chandravati Madam. And we are recording this and circulating this so that knowledge can be enhanced. I would like to share my screen. So ladies and gentlemen, I bring greetings from Kolkata. As you all know, it's the city of joy. We are very proud to have 6 Nobel laureates and 1 Oscar winner from this city. But more importantly, the first IVF baby was born in this city by none other than Dr. Subhash Mukherjee. Now, the topic I've chosen today is very close topic to my heart, unexplained infertility. Now, the main causes of infertility, all we know, are divided between male, female, and unexplained. Sometimes the cause is both involving male and female. When we were students, we were told, remember it easily, 1/3 male, 1/3 female, and 1/3 unexplained. But this recent paper has shown in Human Reproduction Open that more you investigate the infertile couple, lower is the incidence of unexplained infertility. So what is concise infertility workup? In many centers, because of the cost, only history taking, pelvic ultrasonography, and semen analysis. Only after that, we start treatment. It is said that it is cost effective and many patients require one-stop approach. They do not want to come repeatedly. So infertility workup has become less comprehensive in many centers. But it has been shown the pregnancy rate after 1 year in this group where we don't investigate is actually lower. The cumulative pregnancy rate is 46%, and we investigate more, it is coming up to nearly 58%. And also the diagnosis of unexplained infertility is lower if we investigate more. It will come down to 23%. As I show you to you in the previous slide, it is coming down to 25 or 23%, and not 30% if we don't investigate them extensively. Now, the reason I'm so much interested in unexplained infertility, because it's extremely frustrating. It is extremely annoying to the couple and as well as to the doctor, because if we do not know the cause, how are we going to treat it? And many patients think we are treating them blindly, and they come to us and say, I'm so unhappy. You are not finding any cause, and you are saying you go for this treatment, you go for that treatment. How do you explain it? How do you justify? Therefore, many authors are now saying that unexplained infertility should actually be called an undiagnosed infertility. So basically, there is a cause. If we say unexplained, so we explain to our patient that we haven't been able to diagnose it as yet. That doesn't mean there is no cause. So why it remained undiagnosed? Maybe we do not have specific tests. Sometimes we get false test results. Like I'll give you a simple example. You do a hysterosalpingogram and you see it's a bilateral cord wall block, maybe because of spasm. And when you do a laparoscopy, the tubes are open. So basically, we are on one side of a thin blue line, on one side we know the cause, other side we do not know the cause. So when we have done an HSG, we knew the cause, but as soon as we have done laparoscopy, the tube is open. So what do you tell your patient? Now, what happens is, because we do not have any test to diagnose many factors like peritubal adhesions, sometimes pelvic factors like endometriosis, without doing laparoscopy. Nowadays, we don't do laparoscopy in each and every patient. We have very good 3D ultrasonography that sometimes tells us the adnexa is adherent. So we can guess, but we definitely do not know. I was told by my teacher that fallopian tubes are like good wicket keepers. So they just go and catch the ball. So when the egg comes out, the fallopian tube should be mobile. It will go and catch the egg. And sometimes the fallopian tubes are stuck. So although they are open, they are unable to pick up the egg. So we call faulty egg pickup. It could be there is a tubal transport problem. So if you think about the physiology, within the fallopian tube, it's a one-way traffic. The traveling is actually from the lateral side to the medial side. So from the fimbral end to the cornual end, egg is getting in, and embryo, after the preparation, it will go inside the uterus. So it's one-way traffic. So the sperm has to swim against that one-way traffic. So sperm is coming from the medial side to the lateral side. Sometimes what happens is there is apparently bidirectional motility, and that is one of the causes of ectopic pregnancy. So maybe the tubes are open, but they're not functioning well. It may be we are not picking up low ovarian reserve, because as we know, AMH and antral follicular count, they are good. But many patients, you will agree with me, they have good AMH, but low antral follicular count. Sometimes we are seeing poor AMH, good antral follicular count. So there is some subtle poor ovarian reserve cases which we are not picking up. Next is the sperm factor, which is not picked up by the routine semen analysis, like sperm function tests, sometimes DNA fragmentation index. Finally, the endometrial receptivity may be a problem. It may be an implantation failure. Maybe the window of implantation is not correct. So I say the synchronization, and I often explain to my patients, suppose you have a mango tree and your mangoes are ready on Wednesday and your guest has come on Sunday. What do? You have mango, but the guest cannot get fresh mangoes. And that is what is, we have to give examples to our patients because they don't understand science. So that is, I say, synchronization. So if you do like this, you have good embryo, good endometrium, but it's not synchronized. So that is why it's not implanting. Now, the question we ask to ourselves, whether we should perform extensive REACT tests for all couple for diagnostic accuracy, or we should do simple tests and just start the treatment. Now, why do I ask this? Because we need good embryo, we need good endometrium, and eventually that will lead to healthy pregnancy. Now, we can look at the embryo. We are transferring in blastocyst stage. We are doing PGT. We look physiological changes in endometrium by ultrasound and also by physiological evaluation by ERA, endometrial receptivity array. Now, the question I ask that whether we should do tests or more, because what we often say, even if we don't find any cause, we say the treatment is empirical. Now, what is empirical? Empirical means you are giving something without knowing the cause. Suppose you are offering ovulation induction. She's ovulating. You are doing IUI. The male factor is there. You are doing IVF. Why? That is why we are calling it empirical. But what we have found that if we treat early endometriosis, mild tubal factor, mild male factor, immunological causes by IUI, the success is there. By IVF, success is there. So the treatment is very similar. Maybe the subtle problems are there, which we are unable to diagnose because we haven't done all the extensive tests. Now, once you know it is an unexplained infertility, you have to plan your therapy. We have two groups of treatment, two divisions. On one side is the expectant therapy, and the other side is aggressive therapy, or you can call active management of infertility. Now, the question is whether you should do expectant management and then go for aggressive therapy, or whether you should go for aggressive therapy immediately. It is said if the patient is young, less than 35 years, and she has a duration of less than 3 years of infertility, definitely you should go for expectant management of 6 to 12 months. But if she is older, more than 35, and the duration of infertility is more than 3 years, then we should go for active management of infertility. Let's look at the expectant therapy. Basically, for these patients, the monthly spontaneous fecundity rate is less than 5%. Now, normal spontaneous fecundity rate in a healthy couple is about 20 to 30%. But in those patients who are not conceiving of unexplained infertility, even if you don't do anything, some of them will get pregnant. It has happened so many times to me. I've asked the patient, they have come with 3 years of infertility. I've given her some investigations and suggested a treatment which they didn't agree at that time. 3 months later, she came back saying, sir, I got pregnant spontaneously. We don't feel embarrassed about it. We know there is a background success rate. And apparently, if these patients wait for 3 years, the success rate is 60%. If they wait for 5 years, the success rate is 80%. But who is going to wait that long? Patients are very impatient. They do not want to wait because they want instant result. And the more frustrating is when we ask them to do expected treatment, we do not know which couple are going to get pregnant and which aren't, and within what time frame. So patients want assurance. So if we ask them to do expectant treatment of 3 years and after that said, sorry, you didn't get pregnant, now come for an active treatment, they said, why on earth you have waited for such a long time? Now this paper came out a couple of years back, said that apparently we are over-treating the couples with unexplained infertility. And apparently it is happening in 1/3 of all the infertile couple. And it has been suggested that in order to avoid that unnecessary fertility treatment, we should have a strategy, and that will be operating at multiple levels. So there should be some guideline. There are guidelines from ASRM, there are guidelines from ESHRE, and I'm sure there will be guidelines from ISAR to all us, so that if we are all singing in the same tune, all our patients will agree whether they're going to Dr. A or Dr. B or Dr. C. Now, what is active management? Active management is treating someone actively. It's like active management of labor. So we are not just wait and see. Now, NICE guideline, which came from UK and also in the Europe, people don't like IUI. I've worked there, so majority would go ovulation induction, timed intercourse for a while, maybe 1 year or 2 years. If it doesn't work, then go for IVF. Do ovulation induction with gonadotropin, but still they are not very favor of IUI. American people believe in IUI, and they are saying 3 cycles of IUI followed by IVF. And it is said if the woman is young, if the ovarian reserve is okay, many a time, as I told you, maybe there is some debris, something is blocking the fallopian tube. So tubal flushing, which you can do by hysteroscopy, you can do by saline infusion sonography. Sometimes we do hysterosalpingography. And of course, if you do a laparoscopy, you'll be able to flush the fallopian tubes, but also pick up other subtle problem of tubal adhesion, early endometriosis, etc., which you can then treat. So instead of going straight away for IVF or IUI, if the patients are young, we should treat them actively, but do some less extensive treatment. What is the aim of our treatment? We want to increase the monthly fecundity rate or monthly pregnancy rate. How do we do it? By improving the gamete quality, by improving the gamete number, and facilitate the gamete interaction. So bringing the tubes, bringing the eggs within the fallopian tube, so that instead of 1 egg, there are 2 eggs, or sometimes 3 eggs, and bring the sperm to the egg, and that will help in fertilization. Now, why do you do it? By super ovulation or controlled ovarian hypertension. What do we mean by super ovulation? That means someone who is ovulating, still we are giving them ovulation induction. So Americans call it super ovulation, British call it controlled ovarian hyperstimulation. It corrects subtle ovulatory disorder. It will increase the number of peri-ovulatory follicle. It will increase the size of the ovary and bring it close to the proximity of the fimbrium. It will increase the tubal vascularity to enhance the ovum pickup mechanism. With the
contact 14.
The fertilizing capacity. The fertilizing capacity and IUI will bring the more sperms close to the egg. When to treat this patient depends upon woman age, duration of infertility, and previous pregnancy history. Now, if we go through this algorithm, if the patient is less than 35, duration of infertility less than 3 years, expectant management maximum up to 2 years, maybe 1 year if your patient doesn't agree, and then you do ovulation induction along with 5 or 6 cycles. If it doesn't help, then go for IVF. If its duration is more than 3 years, in younger patients, still don't do expectant management. straight away go for HMG IUI and then IVF. If the patient is between 35 to 39 and the duration of infertility is more year, don't waste 6 cycles of ovulation induction IUI, only 3 or 4 cycles and then go for IVF. If the patient is older, irrespective of duration, straight away go for IVF. That is my opinion. Some people do 1 or 2 cycles of IUI, which many of you, I'm sure, are not going to agree. We can use clomiphene citrate for unexplained infertility. The success rate is actually very low. Pregnancy rate per cycle is only 5%. So Shiladitya Bhattacharya, a very good friend of mine in Aberdeen University, has written a paper showing that expectant management and clomiphene citrate are all the same. You have to treat 40 patients with clomiphene citrate to get 1 pregnancy. Is it worth? You can treat with letrozole. Now, I'm not talking about clomiphene and letrozole for PCO. I'm talking about for unexplained infertility. Again, the success rate is low. Of course, if you add letrozole with gonadotropin, then less dose of gonadotropin will be required and you get higher number of follicles and some of them may be converted to IVF. When you're using gonadotropin, pregnancy rate is still low, only about 7%. But if we add IUI along with that, the pregnancy rate increases. It is said there is no significant difference in the live birth rate between clomiphene and HMG for unexplained infertility. So we are talking about something around 5 to 10% pregnancy rate per cycle. Is it worth putting the patient through that? Yes, if they're happy to wait, if they're not economically viable, then definitely we can do that. And there is a high cumulative pregnancy rate. When we do IUI alone, we do not stimulate them, then the success rate is again very low, around 4 to 7%. So there is no role of IUI in an unstimulated cycle. But if you do clomiphene with IUI, success rate is very low, similar to IUI alone. Finally, gonadotropin stimulated IUI cycle are much better than IUI alone. Now, this paper published in Lancet said intrauterine stimulation, intrauterine insemination with ovarian stimulation versus expected management, when you compare, it's a randomized control trial in 2 centers. And what they found, the IUI with ovarian stimulation is very safe and is effective in women with unexplained infertility who didn't conceive naturally. So instead of giving them clomiphene, instead of giving them letrozole, they straight away went for gonadotropin stimulation and the success rate was good. And it jumped from 8% to 18%. 8% to 18% when gonadotropin stimulation was given. And we all tell our patients with IUI, the success rate is always less than 20%. So maybe 10 to 15% is what we hope. And the success rate is majority in the first 3 or 4 cycles. After that, it will plateau. So many centers will only do IUI, maximum up to 3 cycles, maybe 4 cycles, not after that. Another paper published in Lancet 3 years back showed that stimulated intrauterine insemination, stimulated ovarian stimulation and intrauterine insemination is the ideal treatment for unexplained infertility. But they said if the patient is older than 35 years, then straight away go for IVF. But they say optimum first-time treatment for young women is not very clear. So don't jump to stimulated IUI straight away. Although it's an effective treatment, you have to wait until you feel the time has come to do it. Now let's look at the evidence in the Cochrane database showed that you compare different treatment. When you have controlled ovarian stimulation with IUI, it results in higher cumulative birth rate in comparison to the expected management without controlled ovarian hyperstimulation. That is what I've been telling so long. So it has also been supported by Cochrane database. Now treatment with IUI in a natural cycle, without stimulation gives a higher cumulative live birth rate compared to treatment with timed intercourse with controlled ovarian hyperstimulation. So it is true that IUI without ovarian stimulation is better than ovarian stimulation with timed intercourse. And finally, what we have to remember, the stimulated cycle is good, but that will give a higher live birth rate compared to IUI with a natural cycle. Now, let's compare IUI versus IVF for unexplained infertility. In someone who is young, everything is fine. There is no evidence of any difference between the cumulative pregnancy rate with IVF or IUI. And People say the initial treatment should be IUI, don't jump to IVF straight away. But it is also true the pregnancy rate will be higher. So maybe for IUI, you have to wait 6 cycles, and maybe IVF, you can get pregnancy within 1, 2, or 3 cycles. Now, this debate whether you should do IUI then IVF or you should go for IVF straight away continues. And if you look at very famous people, they're still divided. So on one side, William Ombellet and Rick Van Ekelen are saying the IUI first and then IVF, whereas Bill Ledger and Kevin Doody are saying, no, don't waste time, go for IVF. So jury is still out. We have to individualize our decision according to the patient. Now, this study was done in New Zealand by Cynthia Farker group, and what they showed that IUI should be used as a low-cost, less invasive alternative to IVF for couples with unexplained infertility. And they are suggesting do 4 cycles of ovarian stimulation IUI, of course with gonadotrophin, followed by 1 or 2 IVF cycles, and that will have higher cumulative live birth rate in comparison to straightaway IVF, and the total cost will be low. Total cost per live birth will be low. So do 4 cycles of IUI, then 2 cycles of IVF rather than straightaway going for IVF. Another Cochrane database published by our friend Shiladitya in 2015 showed that IVF is associated with higher live birth rate than an unstimulated IUI. So that is why British people, they don't do IUI. They said either you do ovulation induction timed intercourse or you go for IVF. In women pre-treated with clomiphene, IVF appears to be associated with higher. So those who had clomiphene treatment and IUI before didn't respond, they will have a better rate. However, the treatment naive patient, that is those who had never had any treatment before, if you put them on one side IVF and one side IUI, the success rate will be more or less same. And another Cochrane database study showing there is insufficient evidence in the difference in live birth between expected management and other intervention. So what interventions we have? One is ovarian stimulation, one is IUI, one is ovarian stimulation plus IUI, one is IVF or XC. So to start with, expected management should be given importance. Compared to the expected management with ovarian stimulation, the risk of multiple pregnancy is there. That we have to face, and we do not want higher order multiple pregnancy. There is insufficient evidence of difference between IVF and expected management in terms of multiple pregnancy. So when you're doing IVF, multiple pregnancy rate can be controlled because you're transferring only 1 or 2, ideally 1 single blastocyst transfer. So with IUI, the criticism is your multiple pregnancy rate is high. With IVF, although you have many eggs, because you are transferring just 1 blastocyst, your success rate is good and multiple pregnancy is low. And therefore, there is no difference in the multiple pregnancy rate. But ovarian hyperstimulation will be there, whether you do IUI or IVF, because these patients will have problem. The Canadian Society are saying that what they say that before going for the advanced therapy early, it will be better. There is in unexplained infertility, benefit of advanced therapy, IVF early gives a better improved birth rate. So the opinion differs. Some people are saying go straight away for IVF, others are saying go for IUI or expected management like that. It will reduce the multiple pregnancy rate, as I've explained to you, because we will be transferring only 1 embryo, but risk of ovarian hyperstimulation will be there, but it is costly and invasive. Now the issue, the cost factor comes, if you do IUI then IVF, it is more expensive than going for IVF straight away, and that has been done by different people in different studies showing the same thing, that going straight away for IVF, it is actually cheaper in long term. But how do you explain to your patients, particularly if your patients are elderly, if your patients are more than 38 years old, no point doing IUI for them. Now, one very interesting aspect is, suppose you plan someone for IUI and she has developed more eggs, more than 3 eggs, like 4, 5, 6 follicles. Now, we often convert them to IVF and we call it low-cost IVF. Now, this paper compared the success of this IUI converted to IVF on one side and straightaway IVF on the other side. It was shown the pregnancy rate was almost similar. Although we say slightly lower, there wasn't any statistical significant difference. But interestingly, in these patients who actually be stimulated less, and they are mild IVF basically, the miscarriage rate is significantly lower because the egg quality is good, and because we are not giving very high dose of gonadotropin, maybe not very high dose of estrogen, and therefore the endometrium is not hyper responsive, it is not asynchronized, it is more synchronized between the embryo and endometrium. Take home baby rate is very similar, and because it is minimum stimulation, it is less costly and more friendly to the patient. Now, coming towards the end of my talk, there's some people who say for unexplained infertility, if you are doing IVF, always do ICSI because there is less possibility of failed fertilization. So possibility of failed fertilization with IVF, unexplained infertility, is about apparently 34%. And then with ICSI is 10%. Now this is a very old paper. I think the lab facilities are so good, so developed now that fertilization rate is almost similar. So although it was said in earlier paper that ICSI should be practiced for unexplained infertility, that is not correct now. Very few units will do ICSI as a routine. Although it has been said earlier, particularly for the older patient, ICSI. Now, if you have failed fertilization, then obviously next time you will be doing ICSI. Now, coming as to the end, as a conclusion, I will quote this paper. This is the evidence-based treatment for couples with unexplained infertility. They gave a guideline. Let's look at the guideline. They say the current evidence does not support IVF as the first-line therapy. It should be expected management for 6 months, limited course of ovarian stimulation IUI, particularly in patients who are less than 38. But if the patients are over the age of 35, we should go for immediate IVF that will give a better pregnancy rate and shorter time to pregnancy. Now, sometimes patients come and say, no, we want it as quickly as possible. You explain to them, yes, if you go with IUI first, you may not get success, then you have to go for IVF. Eventually, your cost will be higher. So you may go for IVF straight away, particularly for elderly patients. Couples who fail to achieve pregnancy with clomiphene, cited, and letrozole with IUI, immediate IVF results in quicker pregnancy, even in younger patients. No reported difference between the clinical pregnancy and live birth when comparing IVF with the conventional fertilization and with ICSI, which I just mentioned. However, ICSI has been associated with higher fertilization rate and reduced risk of fertilization failure. And two final recommendations for most couples with unexplained infertility. Again, I emphasize the best initial therapy for 3 to 4 cycles would be ovarian stimulation and IUI. They are saying you can use either clomiphene or letrozole followed by IVF. But in my opinion, if you use gonadotropin with IUI, the success rate is much better than clomiphene and letrozole. With clomiphene, you have the risk of ovarian hyperstimulation, which you do not have with letrozole. But with gonadotropin, again, you have the risk of ovarian hyperstimulation as well as multiple pregnancy. Now, there is a pressing need for additional therapy to bridge the wide gap of effectiveness. On one side, we have ovarian stimulation and IUI with oral medication, and on the other side, we have IVF. So we need something effective to bridge this gap. So, ladies and gentlemen, I would conclude by saying, for unexplained infertility, we need to look at 3 important things. One is the ovarian reserve by age, AMH, AFC. Next is the sperm parameter, particularly total motile sperm count, and if possible, DNA fragmentation index. Although DNA fragmentation index have been debated as something we should do as a routine. No, we don't do as a routine. If everything is normal, if it is unexplained infertility, in case of recurrent miscarriage, recurrent implantation failure, then sometimes we have to do it. And tubes, it's not a matter of just patency, it's a matter of if there is any peritubal adhesion, if there is any severe damage, that we need to assess. We are hoping there will be much more ultrasound related investigation with 3D. Narendra sir hopefully will enjoy it. We would love to hear from him that with advanced ultrasonography, if we can assess the fallopian tube much better. And as regards the treatment, expected management in limited resource scenario in good prognosis couple can be given, but it has got low chance of success. And in my opinion, when patients come to us, if we go home and try on your own, they don't like it. They don't like it. So expected management may be okay in the Western world, where people are more educated and more patient. But here on this part of, on this side of the world, definitely we have to treat. But before switching straight away to IVF, one may advise 3 to 6 cycles of ovulation induction and IUI. We may give ovulation induction with letrozole and then ovulation induction with gonadotropin and add IUI, which will definitely give good result. If the patient is young, if the ovarian reserve is good, if the duration of infertility is less, and if there is a cost concern. So thank you very much, ladies and gentlemen, for your patient hearing. I would like to say that this is a very interesting topic, which is very close to my heart. And I would love to, I say these webinars are mainly to exchange knowledge. So in each and every webinar, I actually learn something new by sharing, by hearing what the audience and what the panelists and what our senior chairpersons and chief guests and guest of honors when they give their opinion. Thank you very much once again. Thank you.